Hello and welcome to your newborn lecture. So we've kind of focused on the newborn quite a bit throughout some of your clinical experiences where you've got to measure the baby, go over the APGARs, do a neonatal assessment. So we're going to go into a little bit more detail in this and some of the complications or different things, disorders that you may see with the newborn. In the postpartum period, you are doing a lot of education as a nurse for both parents in regards to the mom as well as the newborn, especially if they are first-time parents and maybe even not just first-time parents. Maybe they had a child 10 years ago and it's been a long time since they've had a newborn. Things do change, and so you are spending majority of your shift providing education to the parents. So when we're talking about the newborn assessment, it's head to toe, just like you would do with an adult. Taking into consideration of what you have learned so far, you want to think about what happened during fetal development, during the pregnancy, what happened during labor, as well as what may have happened or occurred during the delivery process. So you want to be aware of and thinking about risks to the newborn that may have occurred during any of these stages so that you can monitor for changes. It will help guide your assessment and continue to monitor for anything abnormal that may occur. You also want to educate your patients as you're doing the neonatal assessment of things that are normal, things that are, if you see anything abnormal, as well as if you don't see anything abnormal and everything's normal, you want to let the mom know things to call for or when they should be concerned. So this slide or this picture down here on the left on the bottom shows the measurements for the head circumference, the chest circumference, as well as the length. Those are all common measurements that we get for newborns immediately after birth. The abdominal circumference is not a typical measurement that we do. However, you may have to check the abdominal circumference if it's distended more, if it's more concave, if it's not symmetrical. The physician may want you to measure the abdominal circumference because there may be a complication going on. Another part of newborn measurements is their weight. So newborns are weighed initially after birth, and then every night for as long as they are in the hospital, they are reweighed to make sure that they're not losing weight. And it is common for newborns to lose weight within the first, a little bit of weight within the first couple of days, but within 7 to 10 days, they should gain back all the weight that they have lost, unless there's an issue and they're not feeding well. So one of the very first things you do or assess immediately following delivery, and we've already talked about this before, prior to your head to toe, is your APGAR score. So besides breathing and heart rate, what is the other number one thing to determine fetal well-being? That is part of your APGAR score. This has to do with muscle tone. And so after you've assessed their respiratory rate and heart rate, you want to make sure that they have good tone. Babies should never be limp. If they are, there may be an underlying issue, or maybe they got narcotics or something else prior to delivery that made them this way. But tone has a lot to do with whether the fetus is, or the newborn is doing well. So before dressing newborns, you want to assess everything that you can because babies get cold very easily. So you don't want the majority of their bodies exposed for a prolonged amount of time. So you can check their head, listen to their heart, you can listen to their respiratory rate, check their eyes, their nose, their mouth, their ears, their neck. If they don't have long sleeves on or pants, You can even assess their arms and their legs, hands, and feet um, as well prior to undressing them. So you're starting up at your head where you're checking the shape, whether it's round, if they have any molding, caput, cephalhematomas, if their head is symmetrical, if it's normal head circumference, so is it smaller or larger than what it normally should be. You're checking their eyes to make sure that they're reactive. You're checking their nose to make sure for nasal patency. You're checking the ears to see if they align with the outer canthus of the eye. If they're low set, that could indicate Down syndrome. And then you're checking their mouth and make sure that it's pink and moist, their mucous membranes are moist. And then you're going to fill the top of the palate. They have a soft and a hard palate. And one of the reasons why you assess that is not only are you checking for cleft palate, but it's also to assess their sucking reflex. And then you're going to come down to their neck, make sure that it has all the creases. You're going to check the clavicles to make sure that you don't hear crepitus, so the kind of the Rice Krispie popping noise that you would hear if they had a fractured clavicle that may have been injured during delivery. Listen to their heart. You're going to listen to their respiratory rate. You're going to check their arms to make sure that they're symmetrical and they're moving them. If one of their arms limp, that may indicate that they had an injury during delivery, either a fractured clavicle or some kind of nerve brachial plexus injury. So they should be moving both their arms and legs. They should be equal in length. You're going to check their hands to make sure that they have all their fingers, as well as on their feet to make sure they have all of their toes. Axilla, you're just check. That's usually where we check a newborn's temperature. You're checking their abdomen, listening to the bowel sounds, making sure it's round, that it's not concave. That could indicate some other intestinal issue. Liver, spleen, kidneys. Mainly you're not palpating their liver or spleen or their kidneys, but when it's talking about that, you're making sure that their bladder and kidneys are functioning by checking their diaper. So when they have a wet diaper, we want to make sure that we're marking down every time they have a wet or poopy diaper. Not only does that tell us that their systems are functioning and that their anus is patent, but also that you're measuring whether or not they're actually getting breast milk or formula. So that's one way to tell if a baby's actually getting milk, is by checking the amount of output they have. You want to look at the umbilical cord, make sure that it's not red around it, that it's not bleeding, that it hasn't come, or it's intact and in place. That'll dry up. It usually takes 7 to 14 days for your umbilical cord to dry up completely and fall off, but they all will have a cord clamp on while they are in the hospital up until the point when it dries, and then once it dries, we can remove the cord clamp. You're going to check their femoral pulses. You're going to do the Barlow and Ortolani movement that checks for hip dysplasia. You're going to check to make sure that their legs are equal in length. Genitalia, anus, and spine. So you're checking females. Sometimes they can have vaginal tags. That's normal. Female newborns typically can have like a white creamy discharge, and that is normal because of all the hormones that have come from the mother. Sometimes it can be a little bit blood tinged for the females, and that is normal, okay, as long as it's not bright red bleeding. You're going to check for the male to check where the urinary meatus is. Make sure that it's midline and center. Otherwise, they can have hypospadias or epispadias. Sometimes that will cause complications with their urinary stream. Most of the time, those aren't surgically repaired, but if the parents would like them, then the pediatrician can do a surgical repair on those, but that is done later once the newborn's a little bit older. They don't do that initially after birth. And then with the males, you also want to check to make sure that they have rugae on their testicles or their sac, as well as whether the testes, both of them, have descended or not. And then you're going to turn the baby over and check their spine to make sure that it's straight, that it's intact. Look for whether they have a sacral dimple or not. And then the only way to check for anal patency is whether the baby has a bowel movement or not. And then we perform a variety of reflexes, which I'll go over here on the coming up slides. So after you've done the APGAR score, then you're going to go proceed on to your newborn assessment, getting all the weights and measurements. Typically, newborns lose 5 to 10% of the weight loss within the first few days, and then that is regained within 10 to 14 days. So you want to make sure you're monitoring the baby's output and their feedings so you can let the physician know. If a baby isn't feeding well or they have poor feedings, then you're going to see more of a significant weight loss. Typically, if those newborns have more than the 10% weight loss within the first few days, they are monitored and kept in the hospital longer, as well as helping the mom getting lactation if they want to breastfeed, having lactation consultant come in and assist them with breastfeeding. And sometimes, even though they strictly want to breastfeed, the physician may talk to the mother and ask her to supplement with formula to help get the baby's weight back up. Newborns, because they work very hard during delivery, just like the mom does, they typically sleep 16 to 20 hours a day for the first 2 weeks. So that is not abnormal for a newborn to sleep a lot. Remember, their blood flow from the umbilical vessels and placenta stops at birth, so then they start circulating their own blood, and their lungs are expanding and they're breathing on their own as well. Some of the things that close in the heart are the PDA, or the patent ductus arteriosus, the foramen ovale, and the ductus venosus. Sometimes these don't close right away after delivery, and that's okay. You might hear slight murmurs on newborns, and most of the time they're benign. The physician doesn't do anything with the murmurs. Unless it's more of a significant murmur and it worries them, then they might perform an echo on the newborn before they are discharged. Remember, within the first 24 hours after birth, it is normal for a newborn to have acrocyanosis, meaning their hands and feet are going to be blue, but the rest of their body should be pink, meaning that their circulatory system is functioning properly. If after the 24 hours they still have blue hands and feet, then there might be some sort of circulatory system issue or disorder that the physician would want to do an ultrasound or an echo to make sure that everything was okay. There's another test that we perform, a CHD test, and I'll just discuss that a little bit further in this lecture. Newborns lose heat very rapidly, and so they get cold very easily. They don't have the same shivering mechanism as adults, so you don't typically see newborns shiver. One way to you want to make sure that the mom is doing skin to skin, or they have the baby swaddled in a blanket, as well as always having a cap on their head initially for the first few weeks of life, because they lose a lot of heat from their head. When babies get cold, it can cause a lot of issues. They're using up more oxygen. They're using up their glucose stores and brown fat. So a lot of times when newborns get cold, they become hypoglycemic. Newborns are weighed immediately at birth, as well as every day that they're in the hospital. And they typically do it on the night shift, so they'll weigh them every night to monitor their weight loss. When you're looking at a newborn's head, you want to check and make sure it's round and symmetrical. Some babies will have molding if they were just delivered or within the first 24 hours, and where it's more elongated. Sometimes they can have caput, which is the edema, or cephalhematoma, which is a blood collection. So you want to check their head and be also looking at their suture lines and checking the fontanelles. Those are the little two soft spots on a newborn's head. They have one on anterior as well as posterior. You want to make sure that they're not bulging or sunken. Extreme sizes in a newborn's head may indicate either microcephaly, hydrocephaly, or an increased intracranial pressure. So if you have bulging fontanelles on a newborn, it usually has to do with increased intracranial pressure. If they're sunken in, that has to do more with dehydration. Typically, you're not going to see sunken fontanelles on a newborn within the first 24 hours. Now, if they go home and they're at home and they're poor feeding and not taking in enough water during either bottle feeding or through breast milk, then you might see sunken fontanelles on the newborn. And you want to educate your patients on looking for that once they get home, especially if their baby isn't feeding well. You're going to look at their umbilical cord initially after birth to look to make sure they have 2 arteries and 1 vein. They will get a cord blood sample to get cord gases off the umbilical cord, as well as if the mom is O negative, they will draw blood to check for a type and screen to check the newborn's blood type so they can determine whether the mom needs to receive RhoGAM or not. When we're talking about a newborn's respiratory effort, within the first minute of birth, babies should cry. You should hear a loud and lusty cry. They shouldn't have any dyspnea. They shouldn't be retracting. Their normal respiratory rate is 30 to 60 per minute. They shouldn't be using their diaphragm or abdominal muscles. Remember, babies are obligate nose breathers, so you always want to check and make sure their nares are patent and that you're not, during breastfeeding, that their nose is away from the mom's breast so that they're able to breathe. You also want to make sure that they don't have any circumoral cyanosis, because that could indicate some circulatory issue. So here are normal newborn vitals. Their heart rate is typically 120 to 160. Sometimes during sleep, it can be a little bit lower, usually like 100s, 110s, and that can still be normal as long as their body is pink. If they're crying or agitated and upset, sometimes their heart rate will be a lot quicker, even up to 180. So you always want to make sure when you're listening to a newborn's heart rate that you're checking for 1 full minute, as well as when you're checking their respirations. A newborn's respirations are 30 to 60. The reason why you count respirations for 1 full minute is, remember that newborn's respiratory rate is irregular, meaning that they can breathe very quickly over a few seconds, and then they slow or sometimes have apnea for a few seconds before they start breathing again. So they don't breathe regularly on a normal pattern, and so that's why you want to check for 1 full minute. Newborn's temperature, the normal range is 36.5 to 37.5. You will need to know all the newborn vital signs, remember this. And so when it comes to testing, you may see questions where it's listing vital signs or an assessment finding in a newborn. And in order to know if something's wrong or what you're going to assess first or be more concerned about, you have to know what the normal newborn vital signs are. So we already talked about narcotics and the baby being limp following delivery. So one of the things when you're listening to a newborn's heart rate in regards to what they were doing during delivery or during labor on the fetal monitoring. So if you had the fetus on the fetal monitor's heart rate was 140s to 150s, what do you think you would expect the newborn's heart rate to be immediately following delivery? Well, you would expect that it would be the same. So if you have a newborn who was trekking along during labor, they were 140s to 150s. Within the first 1 to 2 hours after life, it's going to be the same. They're going to stay 140s to 150s. Now, going even further into this, when we have a mom who had chorioamnionitis, which is an infection on the amniotic sac, the baby would typically be tachycardic in utero, primarily because there's an infection and the mom probably is going to have a fever. And so when the mom gets hot, it causes the baby to get hot, and they get a fever, and that's what increases their heart rate. So babies typically, when they're in an infected environment, are going to be tachycardic. So if they were in the 160s, 170s during labor and prior to delivery, their heart rate is going to probably be within the first 1 to 2 hours after life, 160s to 170s as well. So the newborn adjusts and regulates their heart rate following delivery. If you get to the 4-6 hour mark and they're still 160s, 170s, 180s, that is not normal. So only within the first few hours, they're going to be the same as during the labor process and prior to delivery. If you get further out, their heart rate should lower and adjust to what the baby's doing, whether they're sleeping or calm. So you would want to be concerned if 4 to 6 hours out, the baby was still very tachycardic, and you'd want to let the physician know about that. And talking about their tone and breathing and their heart rate and skin color with regards to their APGAR, if they have no tone, they might not be breathing or they may be struggling to breathe, meaning their heart rate typically, if you have these other issues, is not going to be 120. It'll be less than 120. And the baby is probably not going to be pink either. They're going to be more of a gray hue, meaning they're cyanotic, so they're not getting the oxygen and circulation pumping like they normally would. So prior to your head to toe assessment, one of the other things besides the APGAR that you always want to do first, especially up on the postpartum floor, is to obtain the newborn's vital signs. Why? Because if you're messing with them and doing all these reflexes and different checks, they can become very agitated, and it'll be very hard to get their vital signs once they're agitated. So you want the newborn to remain calm, and hopefully they're not crying, in order to better hear their respiratory rate and heart rate. Because when they're crying, sometimes it can be very hard to hear their heart rate and respiratory rate. So you always want to assess their respiratory rate and their heart rate first prior to their taking their temperature, because they do not like getting poked under their armpit either. Typically, we do not do blood pressures in newborns unless there's a cardiac issue or some other underlying medical condition where the pediatrician wants you to check a blood pressure. So here on this slide are some of the reflexes that we do. This one up here is the plantar grasp where you're putting your finger right below their toes and they will curl them over. Same thing as here where you're checking for the palmar grasp. So you're doing the same thing, putting your thumb right below their fingers, and they'll curl them around your finger. You're also checking, this is rooting, where you're checking to see if they have feeding cues. When you're checking the newborn's mouth and checking for the hard palate, that's where you're checking their sucking reflex. The Moro reflex is up here, where you gently lift their hands up and their back slightly arched off the ground or the bed or whatever flat surface they're laying on. You want to be careful when you're doing this. It's just barely gently lifting them up slightly, that you leave their head on the surface. You don't want to lift that up and then drop them down and have them hit their head. This is referred to as the startle reflex. So once you release their hands, they typically flare out their arms and hands. All of these reflexes are done to make sure the baby's neurological system is intact. This is the Babinski reflex, where you're checking, you're moving your finger from the sole of their foot up to the side and up around just underneath their toes, and that's where their toes are going to flare out. And then this is the stepping reflex. This isn't typically one that we perform in the hospital, but the other ones we do. But if you were to hold the baby up and have their feet touch a flat surface, they will start to step and lift their legs up. And then this is the Barlow and Ortolani maneuver, showing you how it's done, where their hips are rotated and flexed outward to check for hip dysplasia. In addition to all the other assessments, you also want to be looking at the baby's skin, checking their skin color, seeing if they have any Mongolian spots, if they're jaundice, if they have milia, lanugo, vernix, stork bites. When you're checking their ears, if the newborn were to have like a skin tag on their ear or have any issues with their ears when they do the hearing screen, the physician will probably do an ultrasound to evaluate the kidneys. They're one of the reasons why they believe these are associated is because the ears and kidneys develop at the same time in utero. So if you have any issues with the ears or skin tags on your ears, it may indicate a problem with the baby's kidneys. So molding is different than caput. Molding is molding of the bones to help the baby's head fit through and descend into the birth canal. Caput is fluid accumulation, and cephalhematoma is a blood collection under the newborn's scalp. So if you have caput that is 5 centimeters in diameter, then you know that labor dystocia, or stalling out of labor, occurred at 5 centimeters dilation. And that happens because of a prolonged time for the newborn sitting in the birth canal. You want to make sure that you know the difference between caput and cephalhematoma. This is also a NCLEX favorite. You want to know how they occur, where they occur, and whether or not it crosses the suture lines. Remember, caput is fluid, cephalhematoma is blood. This dissolves over time. Sometimes when you have cephalhematoma, because of the blood loss, their serum lab levels may be affected and they're at risk of jaundice. This is seen with cephalhematoma only, not with the caput, because remember, caput is just fluid. So what causes a cephalhematoma to happen? Typically, when babies get cephalhematoma, it's because of trauma that occurred during the delivery. Can also occur from vacuum or forceps use. So if you look at this photo here, caput crosses the suture line, meaning it goes all the way across and crosses the suture lines here. Where the cephalhematoma does not, it's usually unilateral, only occurring on one side, and it will not cross the suture line. And this is showing what molding is, where the baby has more of a elongated shape in their head. After birth, you're going to notice it the most. Within 24 hours, it will resolve and they will have more of a symmetrical round shape to their head. So this is just showing pictures of caput, where it's over here all the way across fluid collection. The cephalhematoma, where it's just here on one side, and then the molding is the elongated shape of the newborn's head. Caput typically resolves, molding and caput both typically resolve within 24 hours. Caput sometimes can last a little bit longer, a day or two, but cephalhematoma will last a little bit longer, take more time for the blood collection to dissolve. And these are just some more pictures of cephalhematoma. This baby here has molding, because you can see the elongated shape of the head, as well as a caput here, fluid collection on the back of the head. So Ballard score, what is Ballard score? You do not need to know how to calculate the score or memorize this chart, but you want to make a correlation between the newborn's gestational age versus how the baby looks following delivery. So these are some of the maneuvers and things you can check for on a newborn to see if their gestational age correlates with how they're looking after they are born. So there's different things you can do: bending their heel to their ear, doing the scarf sign, checking their arm recoil, checking with their wrist to see if they have a square window, meaning when you bend their hand forward, what degree or angle do you have in their wrist, and then the posture of the newborn. So you're going to notice with premature babies that they have different scores as opposed to a full-term newborn. So when you have a preterm baby, it's going across this way. So most of the time, they're not going to have the lanugo. Their skin's going to be more sticky, friable, and transparent. Their scrotum, if it's a male, is going to be flat and more smooth. Depending on the gestational age when they were born, their eyelids may still be fused and not open completely. And then for females, their labia is going to be more flat. So as you get further on this, further in, more over here to where you're getting to the post-term, over 40 weeks, a newborn skin is more leathery, cracked, and wrinkled. So you may see on full-term babies, typically you're going to see a little bit of peeling. They might have a rash. They're going to have lanugo that you will see, as well as vernix with the their testes in a male are going to be descended with few rugae, and then you're going to start seeing more the majora and minora labia is being more prominent. So this is just showing you the different changes from a preterm baby versus a term or post-term newborn. So remember, lanugo is the fuzzy hair that occurs on a baby, and the vernix is like the white cottage cheese, creamy stuff that is born. It's more of a protective layer on the newborns. That lanugo will be washed, or vernix will be washed away once the baby gets their first bath. This is just another slide showing the difference in a premature baby's feet, where it's more smooth versus a 36-weeker or term gestational baby. More than 42 weeks is when you're going to see more of the skin pilling and flaking. The premature babies also have more transparent skin where you can see through their skin. So these are just showing some of the changes that distinguish a preterm infant from a full term or post-term newborn. And here are some of the skin changes that can occur with newborns. Lanugo is the fuzzy hair. Here's the vernix, the cottage cheese like cream. This is milia, and it occurs from sebaceous glands, and that's normal. It will resolve within the first few days after life, typically. You don't want to pop them. They're not pimples, so you want to educate the parents not to pop them as well. This is like a stork bite, and it probably has a little bit here on the eyelid. And then this is one of the Mongolian spots that you would assess for, as well as this baby looks like it probably has a newborn rash as well. These are all normal findings. There's nothing that you have to do for these other than when you're doing your documentation, you would want to include this as part of your assessment. With the Mongolian spot, sometimes they look more like bruising. And so they can occur in other places, not just on the buttocks, but it can also be on the lower back or one of their arms or the upper back. Sometimes it can be on their front of their trunk, but most of the time it's on the back somewhere. But you want to make sure that you let the parents know that those are Mongolian spots, because other people might think that they're bruises. So we've talked about this a little bit in the postpartum lecture as well as at your clinicals. You want to make sure if the mom wants to breastfeed that we're supporting them and helping them, whether you have lactation come in or you as the nurse helps the mom with breastfeeding. If they choose to bottle feed, then that is their choice. They can bottle feed. We do have formula in the hospital that we give parents while they are there. You also want to let them know that spitting up is common in newborns because they have a relaxed cardiac sphincter. What is not normal is if they're having projectile vomiting. So that is something that you would want to educate the parents on to let you know if they were having projectile vomiting. You always also want to educate the parents on burping, whether they're breastfeeding or formula feeding. And then remember, breastfeeding is not a form of contraception. Sometimes lactation and amenorrhea works, but not for everybody. So you want to make sure that you discuss a backup plan for birth control with the mom. The first hour following delivery is what we refer to as the golden hour. This is when babies are most active and awake and are hungry and will typically breastfeed within the first hour of life. Some of the common issues that occur with breastfeeding are latching or positioning, and that is where lactation consultants or you as the nurse come in to be a resource and to help and support the mom so that she can be successful with breastfeeding. Babies, after they are have eaten and are full, they're more relaxed. When they're hungry, they're more upset, so their fists are more clenched together when they're hungry. So after eating, after delivery, they can go through a recovery sleep phase where they sleep for 12 to 18 hours. But you want to make sure that you're waking the newborn up every 3 to 4 hours if they're a term, and every 2 to 3 hours You wouldn't be waking the um, you'd be waking the preemie up to eat, but you wouldn't probably be breastfeeding depending on how premature they were. You would be pumping your milk and giving it to the newborn because they would probably be in NICU. You don't want to overstimulate babies because overstimulation causes the baby to shut down and go into a very deep sleep. And so that's why they don't like to overstimulate premature infants. But you also don't want to overstimulate your newborn either. So, how do you tell if baby's getting a sufficient amount of nutrition? How many wet or dirty diapers should they have in a day? So, that is one way that we monitor whether they're getting adequate nutrition. Typically, newborns should have, depending on where you get your information, it's 6 to 10 or 6 to 12 wet diapers a day. When you're talking about dirty diapers or poopy diapers, 3 to 4 a day. And this also depends on how much or how often you're feeding and whether you're breast or bottle feeding. Remember, there's differences in stools, so they have meconium for the first 24 to 48 hours. And then depending on whether they're breast or bottle feeding, you're going to see the differences in their stool. So the seedy poop is more from breastfed versus the pasty and clay or peanut butter like texture is from bottle feeding. So I got a little ahead of myself on the other slide, but this is where I was talking about vitals, how old they are, if there's any reasons why their heart rate may be different. And so if they had the choreo at birth and their fetal heart rate was 180, you would expect within the first 1 to 2 hours that they're still going to be 180. But if after the 3 hours after birth, that is not normal, and you would want to let the pediatrician know. With the umbilical cord, you don't do anything with it. You always want to make sure that you fold the diaper under, educate the parents that they shouldn't have their diaper above the umbilical cord. You don't dry it out with alcohol. You just leave it open to air and let it dry on its own. This down here with the redness around it indicates this may even be some discharge coming from the umbilical cord, an infection. And so those are things you would want to also educate your parents on to look for. And they would want to call the pediatrician. Or if you notice this while the newborn was still hospitalized, you would want to call the pediatrician. Babies who, in regards to bathing, we typically don't bathe newborns right away following birth because they get cold very easily. So you want to make sure that you're monitoring the newborn for 8 to 10, sometimes even 12 hours after delivery, making sure that you've gotten multiple um, temperatures on the newborn, that they're feeding well, that they're not hypoglycemic, they're keeping their blood sugar up, and they're staying warm before you bathe the baby. Depending on where you work, they will do the first bath is a submersion or tub bath. Other places may not do that, where you're doing more of a sponge bath and washing around the umbilical cord. Once the baby goes home, they should be the parents should be educated on no tub baths. You don't want to submerge the cord, wash around it with warm soap and water in order for it to dry and heal and fall off on its own. The only time that you would bathe a newborn immediately following delivery was if the mom had an infectious process such as HIV or hepatitis B. Those are the two main reasons why you would bathe a baby immediately after delivery. You want to make sure that you bathe them right away so that you can vaccinate and give them their medications. So when we're talking about delegation, You already know that NCLEX focuses a lot on delegation, and so these are some of the questions you're going to see on the NCLEX. So when you're thinking about newborns or talking about newborns, you want to know which newborn you would be able to delegate or give to an LPN to care for based on their scope of practice if the newborn was stable. So if you determine that the newborn is stable, what do you need to know? You need to know if they have normal vital signs, what their history was. Do they have an IV? Did the mom have chorioamnionitis? Are they receiving antibiotics? Are they getting medications because they have HIV? So if the newborn is not stable, that is not a newborn that you would want to delegate to an LPN. So just remember the LPN's role in their scope of practice and which newborns, if you were given a scenario, would you be able to delegate to an LPN? So in the US, the majority of males are circumcised, but everywhere else in the world, it is a very small percentage. They used to be more common here because Access and some of the insurance companies cover them. But now it is considered a cosmetic procedure, so not a lot of insurance, and especially Access, does not cover this because they don't deem it medically necessary. One of the things, these are just different, Gomco clamp, the Mogan clamp, and the Plastibell are different procedures that a physician can do to perform a circumcision. I know it looks torturous when the baby's strapped down here on this plastic little insert with their arms and legs held down, but that's in order for the physician to perform the procedure because you wouldn't want the newborn moving. The main thing to take away from this is that if the parents want to have their baby circumcised, that they have to have received or consented for the newborn to receive vitamin K prior to performing a circumcision. If the parents refuse vitamin K and don't want the newborn to receive it, then they need to be informed that the physician will not perform the the circumcision. Pain relief during a circumcision, most doctors will use a local anesthetic where they inject lidocaine. One of the comfort things as nurses that we can do during the circumcision is to give sucrose, which is sugar water. So we'll dip their pacifier into the sucrose and then have the baby suck on that. That's one of the comfort or soothing pain relief measures that we can do as a nurse for a newborn that's having a circumcision. So these are some of the common newborn screening tests or procedures that are done following delivery and prior to the baby being discharged to home. The top photo is showing where the nurse is drawing cord gases or ABGs from the umbilical cord, and also to check the baby's blood type and RH. This is done immediately after delivery. Cord blood banking is optional, so not every patient chooses to do cord blood banking, but that is something done immediately after birth as well. Venous blood draws, so if they expect chorio, they might draw a CBC or blood cultures, and that has to be done through the vein, so you'd have to do a blood draw on a newborn, not just a heel stick. If you did the heel stick, and you were checking, so we do heel sticks for blood glucose to check for hypoglycemia or to check the baby's blood sugar. Also do the heel stick to do the PKU test, which is done at 24 hours of life. That's a newborn screen, and they also get a second one done in their pediatrician's office when they follow up 2 to 3 days later. If they're jaundice, this transcutaneous bilirubin is this bottom tool screening to check for the bilirubin level. If that comes back elevated, then they will order an MBR, which checks the bilirubin and the serum level, the total direct and indirect levels, and that is also a venous blood draw as well. Newborns will also have a hearing screen done prior to discharge. We used to, if they failed the first time, we would repeat it. If they are being discharged and don't want to stay, the baby refers either in one of their ears or both of the ears, then they will set them up for outpatient follow-up. So we don't have to delay a patient's discharge or keep them in the hospital any longer based on whether the newborn passed the hearing screen or not. If they are staying for a few days and they do the initial and the baby refers on one or both ears, then they will come back usually 24 hours later and repeat it. If the second one comes back and they pass in both ears, then there's no follow-up needed. This test is just showing the PKU, the screen that they do, and it checks for a bunch of different disorders. So phenylketonuria, congenital hypothyroidism, galactosemia. It can check for sickle cell disorders, maple syrup disease, cystic fibrosis, toxoplasmosis. There's a lot of different things that it can test for, and they add more and more tests all the time to their list. And like I said, they get one done in the hospital, and then they also get a repeat one done at their pediatrician's office. This is just showing the area that you would perform the heel stick on the newborn. So another screening that we do is the CCHD test or CHD test, which is checking for congenital heart disease in newborns. It's a pulse oximetry test that is done prior to discharge. Congenital anomalies are the number one reason why babies die less than 1 year old. So the PDA, when we're talking about the patent ductus arteriosus and the foramen ovale and some of the ductus venosus, these are the ducts that close after delivery. So before birth, they're all open, and you can see the here and here, they're all open, so blood flow is going through them. And then after birth, they both close. Sometimes they don't close immediately after birth. Sometimes it can take up to 24 hours for these to close. It would just be up to the pediatrician where he wanted any additional testing done or not. So with the PDA, it connects circulation from the aorta as well as what's coming out of the newborn's right ventricle. So with the congenital heart disease test, you're checking for cardiac heart defects, and you're placing the monitor on the right wrist, which is their preductal, as well as their left foot to measure postductal. So you want to measure to see if there's a difference between the preductal flow and their postductal flow. If there's more than a 3% difference, then you can repeat it, and this just shows the algorithm. Typically repeat it 3 different times, and if the baby still fails, then you notify the physician and they'll let you know what you need to do further. This is one of the tests that we do once the baby's 24 hours old. So at the 24-hour mark, we'll do the CCHD screen, the jaundice or the bilirubin check, the transcutaneous bilirubin level, as well as their PKU test. And this just shows when these ducts typically close. You don't have to memorize that. It's just there for your reference. Another thing that we will do on preterm babies or babies born less than 37 weeks, or if they are less than 5 pounds, then we will do this car seat tolerance or screening test prior to discharge, and this is just to make sure that they're able to maintain their oxygenation while they're sitting or traveling in the car seat in the back of the car. Because remember, babies don't always hold their necks up very well, and so it can cut off oxygenation. It also depends on how far the parents live away from the hospital, and depending on the length of their car ride home is how long you're going to do the screening for. So if they live 2 hours away, you're going to run the tests for 2 hours and see if they're able to maintain their oxygen level. If they desat during this screening, you can repeat it one more time. If they fell a second time, then you would let the pediatrician know, and normally these babies would not be able to go home until they're able to maintain their oxygen saturation while being in a car seat. So we do not screen all babies for neonatal drug screen. However, there are indications that we would do this if the mom had a history or tested positive during her pregnancy. All newborns would have a neonatal drug screen. If the mom didn't get tested, because we don't test all mothers either, but baby was showing signs of withdrawal or it was suspected after delivery, then we could get a urine or a neonatal drug screen. So depending on where you work, they are going to have different ways of doing it. We used to do meconium drug screen. So their first stool we would collect and send down to lab to run a drug screen on. When I took students to St. Joe's, they were doing both a meconium and urine screen on the newborns. And now our facility does an umbilical cord segment. So they save a segment of each cord after delivery, and they will keep them up to 48 hours after delivery in case we need to send the cord segment down to the lab to be tested. And the lab will collect a piece of tissue off of the umbilical cord to test for any drugs. The reason why we switched to the umbilical cord segment screening as opposed to meconium is because you can detect drug use or drugs in the system a lot longer and earlier in the pregnancy as opposed to doing meconium or a urine drug screen. If the newborn tests positive, then social work would get involved and they would make a report to DCS, and DCS would determine whether they're going to come out and talk with the parents or do a home screen to see if the baby is appropriate to be discharged to the mother or to another family member if the mother is not able to take the newborn or deemed appropriate to care safely for the newborn once they're discharged. So neonatal hypoglycemia is a huge issue. It is important because it affects brain function of the newborn. Babies can die from hypoglycemia. So you want to act early and act fast. It can also cause respiratory depression in newborns when they get hypoglycemic. Typically, newborns who are hypoglycemic, they may show signs where they're jittery, they're going to be lethargic or sleepy. They're going to have poor feedings, increased respiratory rate, and they can get cold when you have a baby who's hypoglycemic. Or hypothermia can cause a newborn to become hypoglycemic. So the standard treatment is glucose gel. There's a whole protocol that each facility has with a little algorithm that you follow depending on their age after birth and how low their blood glucose level was will determine what treatment you're going to do. Typically in our facility, if we have a low blood sugar, they will do the glucose gel up to 2 times. After that, if their sugar is still low, then they will have to go to either the nursery or NICU for D10 and IV infusion. Risk factors for neonatal hypoglycemia are small or large, or IUGR, small gestational age, large gestational age newborns, if the mom was diabetic, if it's a premature baby, if the mom received a beta blocker such as labetalol, could be another reason why uh, hypoglycemia can occur. So you want to make sure that you're aware of all those risk factors, and depending on those, we have a set algorithm as well that determines newborns who need to have their blood glucose checked following delivery. So not all newborns have to have their blood glucose levels checked. It just depends on the risk factors, how much the baby weighs, their size, and whether the mom was diabetic or not, and if the mom received beta blockers during her labor and delivery. So newborn jaundice or hyperbilirubinemia is the byproduct of red blood cell destruction. So the baby compensates for an increased blood volume of the mother, and you have pathologic or physiologic jaundice. Pathologic jaundice is if it occurs within the first 24 hours of life due to a disease process or concern in the mother that would be causing red blood cell destruction in the newborn. So what might this process be? So if you had Rh compatibility, so talking about the mom being O negative, that is one of the reasons, disease processes that can cause jaundice. The physiologic has more to do with other underlying conditions and occurs past the 24 hours of life. So for these newborns, depending on how high their transcutaneous bilirubin screening was, they will order the MBR, which is the serum blood level. Then the doctor will determine on what that level is, whether the baby needs phototherapy or not. But that is typically what they will order, is phototherapy for these newborns. When you have the jaundice, you can see the yellowing of the eyes, the white parts of the eyes, and also their skin will be yellow. Once the bilirubin moves from their bloodstream into the brain tissue, this can lead to an issue that's referred to as kernicterus, and that's very rare. It's not a common thing that occurs with newborns. So here's the phototherapy. We have intensive phototherapy where they have both the baby blanket underneath them as well as the light above them. The important thing that you want to remember with phototherapy is that you protect the newborn's eyes. So they will have those little goggles on to make sure that their eyes are covered. You also want to let your parents know that they're going to be laying under there just with their diaper on, and that is it, and the eye goggles. They need to leave the newborn in there as long as they're not doing anything. So you can leave the newborn under the light to change their diaper. The only time that you want to take them out from the lights is to feed them. And then once you're done feeding, put them back under the lights. The more time that they spend under the lights, the quicker the jaundice is going to resolve. If they don't have the overhead lighting, then they don't need to have their eyes covered. So we already kind of talked a little bit about cold stress. If the newborn gets hypothermic, then that can lead to hypoglycemia, which can lead to respiratory distress and a lot of other issues. So what are some things you can do to prevent heat loss, and how do they lose heat? So these are things that you must know and something that you're going to have to memorize. When we talk about rewarming a newborn, the best way to rewarm them is doing skin to skin with the mother. If after an hour of skin to skin and you recheck the newborn's temp and they are still cold, then we can take them and put them under the newborn warmer. But it's always the very first thing you want to try is skin to skin with the mom. So convection, evaporation, radiation, and conduction are ways that babies lose heat. So convection is from cool air. You want to minimize that by placing newborns away from direct AC vents, fans, or any open windows. Evaporation is water loss from their skin, meaning they're in contact with something wet. So if they have wet blankets, or they're laying even in a wet diaper that hasn't been changed for a while, they spit up on their clothes. You want to make sure that you're changing if their outfit, if they spit up on them, or if they accidentally soaked or leaked through their diaper and peed on the blanket, you want to make sure that you're removing the blankets and replacing it with a dry one. Radiation is cooler objects surrounding the baby that would cause them to lose heat. So if the newborn was um, away from windows, doorways, and outside walls, because walls retain cold air depending on what type of walls you have and windows, then they can lose heat loss that way from surrounding objects that are colder than them. And then conduction has to do with them laying on cold surfaces. So if you were to put them on a scale or something else, laid them on the tile floor or whatever without a blanket underneath or towels, then that's one of the ways they can lose weight through or lose heat through conduction. So you want to make sure if you're laying them on surface that you put down towels or blankets underneath them. So neonatal sepsis can occur in newborns. It's typically from the mom having group beta strep or E. coli, some other infection, as well as if they had chorioamnionitis. If a baby develops newborn sepsis um, due to the mom's maternal history or something that happened during labor, you want to make sure that they get treated right away, because babies can die and go into septic shock, cause basically their cardiovascular system and respiratory system to shut down. So you want to treat these newborns with antibiotics, and you'll typically the physician will order blood cultures so you can determine what type of bacteria or infection that they have. Newborns can be febrile or they can be cold when they have sepsis. So there isn't one way or the another. Typically, they're going to have fast breathing, so they're going to have respiratory distress. They're going to be crying and not being able to be comforted very easily, and they're going to be poor feeders, as well as being kind of lethargic and more floppy and limp. Sometimes you'll see a change in their skin color because of the sepsis. So usually they might have like the grayer or a blue hue to their skin, meaning they're not getting a whole lot of oxygenation or circulation because of this. This is an emergency, and you want to make sure that, just like with hypoglycemia, that you act early and act fast so that you can get it under control and prevent further damage. So when we're talking about small for gestational age, or SGA, or large for gestational age babies, this is different from a baby who is IUGR, intrauterine growth restriction, or a macrosomic baby from a diabetic mother. When we're talking about small for gestational age or large for gestational age, this has to do more with hereditary and genetics. So if you have parents who are short in stature and not very tall, you may have, and very petite, you may have a small for gestational age baby, as opposed to if you have both your parents, they're over 6 feet tall and they're more stocky or muscular build, that you might have a large for gestational age baby. If you have an SGA or an LGA baby, they will meet the criteria typically for blood glucose checks. So you'd want to monitor both of these newborns for hypoglycemia. The SGA baby may get cold easier, so you want to make sure that you're have them dressed in clothes, that you're keeping them bundled up, you're doing skin to skin, you have a hat on them because they're going to have less brown fat and they're going to become cold more easily. They also may be poor feeders, and so you would want to feed them more frequently than you would for a normal size term baby. So when a newborn goes into respiratory distress, there are certain things that you're going to notice. You may see cyanosis, meaning they're not just having the acrocyanosis where their hands and feet are blue, but their whole body is purplish, bluish, gray color, as well as the circumoral cyanosis. Babies will typically have retractions, which is seen here. You can see it through their ribs in the intercostal space, and nasal flaring where their nares flare. Those are not normal signs. Babies will also make that grunting sound if they're in respiratory distress. All of these signs are something that needs to be reported immediately, as well as the nurse doing interventions. So if you have to do blow-by oxygen or a little bit of CPAP, or positive pressure ventilation, which these are things that we are not teaching you to be NRP certified, but those are things nurses would do for these newborns in order to increase their oxygenation and circulation. Remember, we talked about when babies get cold and are hypoglycemic. Those are things that can cause a baby to go into respiratory distress. Newborns can also go into respiratory distress with or without hypothermia or hypoglycemia. There may be an underlying cardiac issue or some other process that happened. Maybe they had meconium aspiration during delivery or swallowed too much amniotic fluid that would cause respiratory depression. So TTN, or transient tachypnea of the newborn, it's kind of an urban legend where typically, and even in your textbook, it says that this occurs from babies not being squeezed from coming out of the vagina. But if you're thinking about it critically, that would mean that every baby that had a C-section would have or should have TTN, and that is not the case. So it has to do more with hormones and CNS depressants, not necessarily the squeeze. The cascade of hormones happening in the body signals to the newborn that it's getting close to delivery, informing the baby to get ready for air following delivery. And so sometimes those aren't always functioning properly and will cause a baby to have transient tachypnea. This is temporary fast breathing. It's sometimes referred to as wet lungs. They may have the nasal flaring, the retractions, and the cyanosis as well. Once the baby is breathing effectively and air is going into their lungs, then and that fluid that's in there clears, then it's easier for them to breathe. So it doesn't last very long, and it also is more common with preterm babies as opposed to term babies. So RDS, or respiratory distress syndrome, is also referred to as hyaline membrane disease. This is a typical condition that occurs with preterm infants. The one thing you want to remember about this is that you want to be careful with the amount of oxygen that you're giving, especially if you had to resuscitate the baby after delivery, because the high amount of oxygen can cause damage to a preterm infant's eyes. And the high O2 creates more vessels in the eyes, or abnormal vessels, and can lead to retinal detachment. So we always are cautious in the amount of oxygen that we're giving to preterm babies. So respiratory distress is caused by deficient surfactant in the lining of the alveoli, which is why it typically occurs with preterm infants, because they're born early before the surfactant was able to develop and be produced. One of the things that we give to moms that help with this is the steroids, or the betamethasone injections, that helps with lung maturity or fetal lung development. So any mom who's at risk of having a preterm baby will get those steroids. So meconium aspiration syndrome is where the baby was stressed in utero. They stooled in utero, the meconium's floating around in the amniotic fluid, and then they aspirated it or swallowed it, and it went to their lungs, either in utero or during delivery. And most times there isn't an issue with this. It doesn't always block the airway, but it can. It can cause respiratory depression and inflammation and other issues. They may develop an infection in their lungs. They may have trouble breathing, so they're going to have all the symptoms of respiratory depression, where they're tachypneic, retraction, cyanosis. We used to do deline or suctioning babies after delivery, either fluid or meconium. That is not a typical or standard process or any longer. It's not evidence-based, so we don't routinely do that. The physician can suction their mouth and nose after delivery if it is indicated. This is not routinely done after delivery. We used to do the bulb syringe, suctioning their mouth and nose immediately after delivery, but that is also not evidence-based practice, and is not routinely done. And just as the suctioning is not something that's routinely done. However, if you were to see it on the NCLEX, a question about this on the NCLEX exam, they would be doing the suctioning. So you don't have to know this. This is just showing you what a different chest x-rays look like when babies have different disease processes. So TTN is more of a streaky look, where the meconium aspiration looks more fluffy. If they have congenital diaphragmatic hernia, they get more of this honeycomb look. Hyaline membrane disease or respiratory distress syndrome looks more hazy. Then pneumonia is more patchy, and effusion is total whiteout. And then the air leak syndromes causes more of the blackening areas. That's not something you have to remember or know how your lungs or a newborn's lungs look on x-ray. It's just more for a reference so you could see the different disease processes and how they may look. So when we're talking about retinopathy of prematurity, we kind of already talked about this with preterm infants, where the retina becomes detached. So premature and low birth weight babies are routinely screened for retinopathy of prematurity. The first exam is usually 4 to 6 weeks after birth, and then you would have it done prior to leaving the hospital. Some newborns, premature babies, depending on how premature they were, may go home before the retina is fully developed, so they will need to have follow-up exams on an outpatient basis. And like I mentioned before, the retinopathy is just an abnormal growth of the blood vessels in back of the eye. So these typically, retinopathy of prematurity occurs for babies who are significantly preterm, meaning they weigh less than 2 pounds, or less than 3 pounds, I should say, are the ones that most commonly may have this issue. So what are some of the newborn medications we've given? We've kind of already defined over it in clinical. Sucrose is for pain relief, and that's typically given if a newborn is having a circumcision. Erythromycin ointment that goes in the eyes. What does it prevent? Infections from bacteria that they encountered during the vaginal delivery process. But the most common one that it's treating is for the STI is chlamydia. Vitamin K administration. Remember, newborns are not able to produce an adequate amount of vitamin K. Their GI tract is sterile, and that is why they don't produce the vitamin K needed for the coagulation to occur. This is given as an IM injection. Most common side effect is local irritation. The Hep B vaccine prior to discharge, and remember, parents can refuse all of these medications. They just need to be given the education on why they're important so that they have informed consent before they either consent to getting them or refuse the medications. HBIG is the hepatitis B immunoglobulin. It is only needed if the mom tested positive for hepatitis B. So if the mom was Hep B positive, they would get both the Hep B vaccine as well as the HBIG. And you always want to make sure to give it as soon as possible within the first 12 hours of life. And this mom who was Hep B positive, their baby would be bathed right away and then given the vaccine. Circumcision per parent's consent. Like I said, majority of the time, because of insurance purposes, parents choose not to have the circumcision done in the hospital, but may delay it and have it done in the pediatrician's office because it is a lot cheaper to do at the pediatrician's office than it is to have done in the hospital. There are some safety procedures and protocols that every facility has. They may not all be the same. They may have a different system. You just want to be familiar with the system that your facility is utilizing. Most of the child abduction codes, at least where I work, they're called Code Pink. So if we have a newborn that's missing or someone were to try to abduct a newborn or a child, a Code Pink would be called, and you would go to the exits, stairwells, different areas to make sure that nobody was walking out or had a big bag that they could hide a newborn in. You want to make sure you can approach them and ask if they will allow you to check their bag, but you cannot make anybody have you do a search, and you don't want to cause confrontation. So you would want to get a good description of the person, what they were wearing, and report that information to security. We have the code, different codes on the back of our badge. Most facilities will have the different codes and the number that you would call. Here's some of the other things that newborns will get. Their footprints done after delivery. They will have a tag. The parents will have a birth. This one is a scanning one for medication administration. And then they'll also get the birth tags. Both the mom as well as the father or whoever their support person and the newborn will all have an ID band so that you can identify the newborn. Anytime you are to take the newborn out of the room, when you bring it back to the parents' room, you always want to make sure that you're checking the bands against the parents to make sure that you're bringing the same baby back to the room. This is a newborn identification paper that goes to the state. The baby's footprints as well as the mom's fingerprint is put on there. And then when the newborn is discharged, they will have 2 identification bands. one of the bands will get placed on here, and that goes to the state as when parents apply for their birth certificate. This is a crib card that most facilities will use that has information that we'll put in the baby's bassinet. And then this hugs tag is what we use where I work, where the little, I call it the baby LoJack, or their alarm system, that if anyone were to take the baby near a stairwell or the exits or near the elevator, it will alarm and go off and alert staff to go and check and make sure that nobody that shouldn't be taking the newborn has them. Sometimes the tags come loose and it'll alarm, but it will tell you on the monitor system whether it's a loose tag or if the newborn's out in the hallway or near an exit. WIC is one of the programs that they have outpatient, women, infants, and children, that we can refer parents or patients to if they need resources with either breastfeeding or formula feeding once they are discharged. It is income based and it's something that they have to apply for, but all parents are informed of this and offered it prior to discharge. And I just found out in the last week or so that we didn't have an inpatient WIC person or office, but they are, Banner University is now going to have an internal WIC office where patients can go and apply and get approved while they're in the hospital prior to discharge.